So good morning, everyone. Welcome back to day 2 of the Overcoming Health Disparities conference. I think we had a very busy day yesterday. I think everybody would agree on that it was a very, very full schedule. And I think what we accomplished is we barely scratched the surface. There were so many interesting themes and research areas and innovative ways of thinking about moving forward that were put on the table. So we really only scratched the surface, but the way I see it is we actually scratched a lot of surface. So I think that will help us then think about how to move forward. This afternoon we'll have a couple of panel discussions in terms of what this all means and how we move forward. But this morning we will have a slightly different focus. We will now sort of go to the federal policies and discuss how they affect what's going on in the Bay Area, what opportunities are there, for improving things here. And I would like to introduce my co-chair, Jerry Flanzer. I will let him introduce himself.
Thank you. I'm honored to be sitting up here to help introduce and have a dialogue with our esteemed leaders, Grant Colfax, Greg Millett, and Donnelly. I suppose I'm here not so much for where I'm now the Associate Dean of Research at San Jose State University. My job is to build research infrastructure, particularly getting community projects going. But my previous life, I guess, right, because I was acting branch chief of Health Services at the National Institute of Drug Abuse, and I was assigned and working with the Office of Behavioral and Social Services Research to lead the charge on health disparities. I don't know if you knew that, but that was, yeah, so this is for me a wonderful opportunity to see what's going on in the White House and what has changed since the days that I was involved. So anyway, I think it's most appropriate that we ask Dr. Colfax and Dr. Millett to come on up. It's funny to introduce people who are very well known to this audience. There's no question. So Dr. Colfax, I'm reading here now, Grant, Director of the Office of National AIDS Policy, where he is responsible for coordinating the continued efforts of the government to reduce the number of HIV infections across the United States. He was formerly Director of HIV Prevention and Research at the San Francisco Department of Public Health, long been a national leader in HIV, AIDS, and prevention. I have read his research, even his work back when he was at Harvard. And we also have Greg Millett, Senior Scientist at the Center for Disease Control and Prevention, CDC. He's the CDC's HHS liaison to the White House on national aid policy. I imagine you work together constantly now. Greg has authored numerous peer-reviewed papers that exploited racial ethnic disparities in HIV among men who have sex with men, correlate of HIV risk behavior among bisexual men of color, and the relationship between circumcision and HIV acquisition among MSM. And Grant, you're going to lead?
I am.
Okay, take it away.
Well, thank you very, very much.
You.
Thank you for that generous introduction, and it's great to see everybody in the room, and many of you have been such mentors to me and others. I'm just so grateful to be here and have the opportunity to talk from the national perspective about implementation of the National HIV/AIDS Strategy. And I'm hoping that we can have a real meaningful conversation here about how do we bring research forward to help the nation with the implementation process, and what have we learned locally in terms of collaborations and innovation moving forward, and how can those models be used to scale up other jurisdictions as they try to implement the strategy, and also realizing that there's some really other great models across the nation, and what can we learn from those. I think this is the way to do it. So just a brief overview of the National HIV/AIDS Strategy. There are 3 salient goals, three goals that the President has asked the nation to achieve. Reduce the number of people who become infected with HIV, increase access to care and optimize health outcomes for people living with HIV, and reduce HIV-related health disparities. I think the national strategy is a remarkable document. It's relatively brief. It has a small number of target actionable steps that are actually realistic and achievable and also data-driven. There are 5-year targets, and we'll come back to that in a little bit. There is an emphasis on evidence-based approaches, and it calls for collective ownership. It calls for federal, state, and local and private entities to come together and really approach the epidemic in an effective way. There's a focus on coordination also across federal governments, and as many of us have experienced at all different levels, there's room for coordination in terms of how we approach the epidemic. And really, the strategy is a catalyst. And I will say that in my brief tenure at ONAP, it's fantastic to come back to the strategy, that we have a document, a blueprint for how to proceed. And for those of you who haven't read the strategy, I really would ask you to do that, because as we move forward as a nation in addressing the epidemic, this is our roadmap. So I just want to call out, just start right from the top. I mean, sometimes we get caught in some of the weeds in terms of thinking about what's effective, what's not. I just want to call out that we have a president who personally supports gay marriage. It happened a couple of weeks ago. I'm sure all of you are aware of that. But when we talk about addressing stigma and discrimination, this is high impact. This is a high impact intervention that I think we all need to really celebrate and think about what this does for our communities and the country with regard to not just HIV prevention, but really civil rights overall. So just to really call that out and make sure that as we think about what we do at the local level, we also keep in mind the big picture and really what makes a difference in lives of people living with and at risk for HIV. So since this is a research crowd, and I struggle because there's this tension between speaking from the policy perspective and then also wanting to have some meaningful dialogue about the research. And so I frame some of these top implementation research questions that we at ONAP are really want to have conversations about. How do we figure this out? What combination of interventions is optimal for achieving the greatest effect? And I know many of you in this room are active in several NIH-supported research studies to try to figure that out, and it's a critical question as we move forward. What are the core structural and operational components of sustainable programs? So when you're actually going to try to implement something in a jurisdiction, what does that actually look like? How do we maintain flexibility? So in some sense, all epidemics are local. So when you approach an epidemic in the epidemic in your jurisdiction, how do you maintain core principles but also achieve the flexibility needed to move forward and be responsive to the needs of the community and the providers? And how do we measure effectiveness of interventions in an ever-changing environment? So if you have shifts in funding, if you have new science coming forward, how do you actually try to measure what you're doing? What's your how do you go from your baseline to your follow-up, given all these different changes? I know all of you are very aware of these issues, but I would just say from the standpoint of policy and in working with stakeholders across the country, these are really very, very important issues for us to try to figure out together. So there are obviously ongoing challenges to implementation of the strategy. I'm not going to go through all of these, but in the rest of my talk, I will touch upon a few. And I would just say that one of the salient points of the strategy that I can't emphasize enough is that it says to put resources where the epidemic is. Put resources in populations at greatest risk for HIV to have the biggest effect. We have limited resources, we have limited dollars, and those all must be used as effectively as possible. So this slide brings home that point, aligning resources with the epidemic. This is a map of, in the blue is HIV, living HIV cases across the country, and the darker colors represent greater prevalence of disease. And one of the things as a result of the strategy that I think was very courageous and important was the CDC realigned its HIV prevention resources according to cases, living cases across the country. So the orange map shows the funding allocation that will be gradually implemented over a 5-year period. So HIV prevention dollars are actually aligned with where the epidemic is. And I will say that, you know, coming from a jurisdiction that had reduced dollars reduced because of other HIV patterns across the country, this was the right thing to do. This is about equity, and this is about being accountable, and moving forward, we will continue to support models of putting resources where the epidemic is in terms of current HIV cases. And speaking of current HIV cases, again, I'm sure all of you have memorized these data, but I think it's worth repeating. Since the strategy came out, there have been new incidence numbers up that have come out, and we see the epidemic is concentrated among gay men, particularly gay men of color, and women of color. So this slide just shows the new infections estimated in 2009. And again, women of color, gay men is where the epidemic is in this country. And I think one of the things that's astounding and really calls for a concerted, sustained, and meaningful response at all levels is a 48% increase of HIV infections between 2006 and 2009 in young black gay men. So just an incredibly disturbing statistic and something that we really need to figure out as a country about how to address that and how to turn that around. Obviously, there are other disparities that we're aware of. Gay men account for 64% of new infections. Black women are most impacted among all women, among new cases among women, which represent 23% of the epidemic. Over half of those cases are among black women, and 20% of those cases are among Latino women. And this, again, just brings home the points that last slide made in a slightly different way, where now we're looking at HIV rates by both gender and race. And you can see here, again, this really drives home the point, both among males and females, that blacks and Latinos have tremendous disparities. And I also just want to call out in terms of continually new diagnoses of HIV among youth, just because, again, we want to address the epidemic among youth. Where the epidemic is among youth is among gay youth. So these are CDC data between 2006 and 2009, looking at new diagnoses, and you can see that male-to-male sexual contact accounts for between 60 and 70% of new infections among youth. So now we're going to get into a little more of the nitty-gritty, and I think one of the points to think about as we move forward is the shifting environment and the shifting understanding of how do we actually address this epidemic in a meaningful way. So going back to the questions about the disparities, particularly among black MSM, what are the underlying causes for those disparities, and how do we address them? And I don't necessarily have the answers to that, but I think that it's clear as 30 years in the epidemic that we have to move beyond an assessment of individual risk behavior as a reason for these disparities. And these are data from a study published by Greg a number of years ago that really brought forth this fact very well. This is summarizing studies that looked at sexual risk behavior among black men compared to white men, and you can see here that there's really no significant difference in terms of risk behavior reported by black men compared to white men. So the underlying theme here is that the disparities that we see in the black MSM epidemic is really not predicted by increases in sexual risk behavior. Also, we don't see increases in drug use. We do see slight differences in STD diagnosis and access to care. So I will come back to that, but I think the bottom line is our tradition, and I think it's not an overcall to call it a tradition, of measuring individual risk behavior and then making decisions about efficacy or about how to move forward only within that context is really not where we need to go, and we need to move and start thinking about different models in terms of our research and implementation to really make a difference and achieve the strategy's goals. So why is HIV infection highest among black MSM? There are a number of hypotheses, and we need more research to really tease this out in great detail. Testing, low frequency of testing, or insufficient frequency of higher testing rates might be actually a better way to put it. High prevalence of HIV among black MSM networks. We just have, there's now such a concentration of HIV in the black MSM communities that just the per contact risk is escalated. I already mentioned the STIs, and then barriers to healthcare and HIV treatment. And I will come back to that theme as we move forward. But I also think that we need to get the basic things right. When we move forward with implementation, not being certain of every aspect of what we're doing cannot be an excuse for not moving forward. We have years of evidence to support these interventions, their effectiveness. We still need to figure out at the local level and implementation level what are the right combinations, but we need to continue to focus on these interventions as we move forward with the humility that we still need to respond to research about exactly how to tailor these pieces and how they fit together to address a given local epidemic. And I think that this slide is an interesting model that was published in PLOS 1 just this year. And this is looking at the MSM epidemic in New York. And what the researchers did was say, you know, if you were they looked at test and treat penetration within the MSM community. So what they said is if everything stayed the same and we didn't change any testing or treatment frequencies in our MSM community in New York, what would happen to new HIV infections? And what they found was the horizontal line, right? Nothing's going to change. So they found that not surprisingly, your HIV incidence stays stable. Then they said if we really penetrated fully and did everything that we could actually do, what would happen? And you'll see, you know, the line went very far down. That's in the bottom line, the optimal combination line. So again, this is consistent with other models of test and treat, where if you actually are able to achieve, you know, true and consistent penetration of test and treat in the community, you're going to have a very dramatic decrease in new HIV infections. But I think what this paper was most salient and most interesting to me was the purple line. That if you get an intermediate penetration of testing and treatment strategies in your community, you still have a very strong and meaningful effect. And they actually showed that they would meet 4 out of the 5 of the national strategy goals if they did an intermediate combination. So as we move forward, let us not let perfection be the enemy of the good. We can do a lot of good moving forward in a way of scaling up testing and treatment. And we must do better. This is the treatment, HIV treatment cascade that, again, I know everybody in the room is probably very familiar with. Bottom line is 28%, only 28% of people living with HIV in this country have a suppressed viral load, and we've got to change that. And I think that the National HIV/AIDS Strategy provides, again, a very strong roadmap for moving forward with that to meet the goals of increasing testing, improving health outcomes, and reducing HIV-related disparities. I'm not going to go into this slide in detail, but Michael Mogovaro and others have really written very eloquently about approaches to improve outcomes along the cascade. So I do want to point out that, again, that as we talk about testing and treatment and improving our national approach, treatment is clearly becoming more widely recommended across the country. San Francisco recommended offering treatment to all in 2010. And I just want to also just from that perspective say that this was really an equity issue. This was an issue that, you know, we were seeing that people living with HIV who had private insurance were being offered treatment early on in their disease. And we thought it was very important from an equity standpoint that people who who didn't have private insurance, who were getting care through other mechanisms, were also offered treatment. New York City followed up with similar recommendations in 2011, and recently DHHS shifted their guidelines to be more in line with recommendations for earlier treatment. But what does this mean? What does this mean for the epidemic, and especially in terms of addressing HIV-related disparities? And I think that we have to be humble and think about how do we actually apply those recommendations now to populations where the disparities are greatest. And again, this is pointing out that HIV infections are following the fault lines of other socioeconomic disparities in this country. This is a study that CDC published looking at HIV prevalence rates among heterosexuals in poor neighborhoods. And again, you can see HIV prevalence really followed other HIV disparities. And I think what's also salient about this paper is that they actually showed that if you look at these disparities, any geographic variation actually drops out. So what this is basically saying is no matter where you are in the U.S., if you have these other associated disparities, your risk for HIV infection is increased. And this slide is particularly, I would say I would say that the data here are actually appalling. What we see here is that as we've moved into more aggressive and more effective treatments, that disparities in mortality have actually increased between whites and people of color. And it's striking to me that as we have increased our effective treatment strategies, that we clearly haven't solved the issue of providing effective care to communities of color. And how do we move forward with that? But I think all is not lost. There are a number of studies that are attempting to look at this, and I just want to review just a few very quickly. HBTN 061 is a study of black MSM across the country, and it was really a preliminary study to design a full community randomized trial in the areas of basically increasing access to testing and treatment and other services among black MSM. So I'm not going to read through this entire slide, but I just would say that this was one of the first national studies looking at linking people to care, looking at the navigation system and increasing testing rates among black MSM with a biologic outcome, looking at decreased viral load. Now, this was not an efficacy study; it was really a phase 2 study. But just to say that this was a very important approach, looking at acceptability and feasibility in the black MSM community to figure out how to move forward to address some of those disparities I just talked about. And I also, the thing that's salient here is that these sorts of studies take a very long time. And you can see that starting from the concept review to the intent to publish the primary manuscript is how many years is it? It's 6 years. And so I think one of the questions as we move forward is how do we bring research forward in an efficient way, in an effective way, so that we can be more effective in the epidemic in a more timely fashion. This is a very complex study. It took a lot of work. There was a lot of community building that went into this. So it's not to say that the reasons for these delays weren't very important and significant and probably improved the study as things move forward. But it does point out when we do these large studies, I mean, 6 years is actually a greater time lapse than we've put for reaching strategy goals. So just some of that context for us as we try to figure out how do we move forward and get the research on the ground so we can implement things more effectively. So I think it's also important to think about, in terms of the disparities and addressing the disparities in care, particularly among blacks and Latinos, there are very salient models that we can look to that really imply that there are ways to address the disparities moving forward. And this is an important study that was done by Kaiser Permanente, and they looked at their cohort of people living with AIDS in Northern California, and they looked at people in care by race and ethnicity, and blacks and Latinos in this study came from lower socioeconomic status and from less wealthy neighborhoods compared to whites. Now, obviously, they were all in the Kaiser system, so they all had access to a managed care organization. And what really stands out about this study is that when they looked at AIDS, time to AIDS, and they looked at mortality, there was no difference by race or ethnicity. So as we think about what's going on at the national level, as we think about addressing the disparities, as we think about the fact that from the slide I just showed you that even though we have more effective treatments, disparities in mortality have actually increased, this really implies that healthcare is a gateway to equity. And I want to bring that forth. I know that Anne's going to talk about the Affordable Care Act in more detail, but we have meaningful change now, and we will have meaningful change going forward. The Affordable Care Act is having positive effects on people's lives as we speak. For example, 54 million additional Americans are receiving preventative services, including HIV screening. We have hundreds of people living with HIV who are now covered under states' pre-existing condition insurance plans. And insurers cannot rescind coverage except for fraud or intentional misrepresentation. These are huge policy changes that are having meaningful effects on our community. In 2014, many other things kick in. There can be no denial of coverage for pre-existing conditions, and as we all know from working in the community, people don't want to get tested for HIV because they're very concerned if they test HIV positive that they will never be able to get insurance. And obviously there's the expansion of Medicaid eligibility to 133% of poverty level, which will allow many people living with HIV, including those who do not have children right now and therefore are not eligible for Medicaid, to gain coverage. So these are really important changes moving forward. But again, how do we address the fact that there's some very underlying factors that would imply that even with coverage, we have a lot of work to do. This is looking at mistrust of HIV prevention and care among Black MSM, Latino MSM, and white MSM. Remarkably high levels of reporting mistrust across all races and ethnicities, particularly high among MSM of color. But this really implies to me that, even as we increase access to care, we have a lot to do to figure out how do people access the care and continue to engage in care, given that this is what many people are thinking about HIV right now. So education remains critical as we improve the outcomes on the treatment cascade. I just said that, so I'll move forward. And then I think as we think about behavioral interventions in relationship to the treatment cascade, this is a little out of order, but the point here is that as we think about behavioral interventions are critical to the treatment cascade. And I think as we move forward from our prior history of thinking about behavioral interventions as changing individual risk behavior, what I think becomes more salient now as we move forward is how do we improve our outcomes by improving the behaviors that we know are necessary to engage in the healthcare system, right? So rather than thinking about behavioral change as reduction in sexual risk, how do we think about behavioral change as now how are you going to continue to go to see your healthcare provider? How are you going to continue to engage in discussions about your care? How are you going to continue to engage about taking your medications, going on medications, taking medications, and so forth? And I think that we have a lot of meaningful research that really shows that adherence is a critical component, and adherence is all behavioral, right? So this is data from the IPREX study that, again, I know many of you know in the room, but it really shows that adherence is critical in terms of efficacy of interventions. And this is looking at efficacy of the intervention compared to the placebo by adherence levels. And obviously, people who adhered to a great degree to the medication, you can see that there was a very high level of efficacy, as shown in the blue line, where people were, for people who were that reported more than 90% adherence to the medication, incidence was significantly lower compared to the placebo arm. But when you reach a self-reported adherence level of less than 50%, there was no difference between the two. So again, adherence is key, and behavioral interventions to increase adherence are key as we move forward to increasing the implementation cascade. And this is salient not only for MSM populations, but also for other populations. These are data from the tenofovir gel study that again showed that adherence was very predictive of efficacy of the agent. So the other piece that I think is critical as we move forward with our implementation of the strategy is moving towards measurement and coming to some agreement about what we actually think is important to measure and how do we measure it and how do we use those data in an effective way on the ground. So this is, I was really happy that just in March, the Institute of Medicine under the chairmanship of Dr. Volberding released a report on monitoring care in the United States. And this was a remarkable document that really did a very extensive review and came up with some very concrete recommendations about how to move forward. And I think that the important pieces here are that the recommendations are parsimonious in terms of really recommending a set of core variables that are most meaningful moving forward. Harmonious, so looking across different agencies and across different approaches so that the same data points can be used. They're achievable, sustainable, and actually usable for all of us. So as we think about how are we going to measure the results of the treatment cascade, how are we going to measure our results of the National HIV/AIDS Strategy, we are very committed at ONAP and very committed at the federal level to making sure that we can bring some consensus to some core variables to measure our effect. And just this report's already having an effect. For instance, the Secretary of Health recently issued a memo to HHS agencies to move forward with developing a core set of measures and also to reduce data burden. So the parsimony here and harmony is very relevant. The data, her instruction was to reduce data collection burden by 20 to 25% across fundees. So I know many of us in the room have lots of reporting requirements, and this is really a major step forward. And just as I called out the Kaiser system as a system that appears to be really addressing health disparities in HIV very effectively, I think it's also helpful to reflect on the VA system for a minute. So wouldn't it be nice at the national level if we had a system where we could say, okay, across our system, how many people have a suppressed viral load, how many people are getting care, and how many people are actually engaged in care? We can do this in the VA system. This is a remarkable database that actually tells us what we're doing and gives us baseline rates and ways to improve our work. So again, this has been done, and so these are great models for us to think about as we think about how do we do this at the local level, and then how do we do this at the federal level across agencies and try to extend our models beyond the VA system. So I know that I need to wind up here, but I just wanted to call out a few local models that appear to be using data effectively and affecting change at the community level. So the DC recapture blitz is quite a remarkable intervention. And what they're doing is they're actually using data in their surveillance data system to locate people who have been out of care for 6 months or more. And then they're actually calling the providers, and they're verifying that, and then they're actually helping the providers figure out how to locate the patients and reaching the patients and re-engaging them in care. So this is a really, I think, strong example of using the implementation cascade model, using local data, working with local providers, and most importantly, reaching out to people living with HIV to figure out how to re-engage them in care. And what's quite salient, I was looking at the state and district data by mortality rates. DC actually has the lowest HIV case fatality rate in the country right now. So obviously we can't draw a direct line from this model to that outcome, but it's quite remarkable. Obviously DC continues to have a very serious epidemic. Prevalence is around 3% across the whole district. But it's remarkable to me that the case fatality rate is so low. And I think we need to look at models like this to think about are there options for us to implement these models in other jurisdictions. So going back to the local example, continuing on the local example, this is going to our experience in San Francisco with regard to the HIV prevention shift. And this really, I think, brings home how long this sort of implementation work takes at the local level. You can see here that we published our HIV prevention plan in 2010, and we didn't start new contracts until September of 2011. So a lot of work that goes into putting out RFPs about helping people shift and start thinking about how are they going to change, about transferring clients from programs that have lost funding to programs that have gained funding. Lots of work at the local level. And I think the point is here is when we think about 5-year goals, we can't say 2 years into the strategy right now exactly where we are on those 5-year goals because quite frankly the resources haven't shifted in such a way that they've actually effectively hit the ground yet. We can really be very clear about what we've done, and we can be very clear about what we think needs to be done moving forward. But to say 2 years into the strategy, oh, we've reduced HIV incidence now by 10%, so we're well on our way on our goal of 25%, is simply not something that we can do yet. But what we can say is what local models are we using, where are resources going, what needs to continue to be done and what research can help affect our decisions as we move forward. So I know you're talking about regional approaches to some degree here, and just to some of the thinking that we've had at ONAP around regional approaches, there are lots of advantages: the innovation, the diffusion of expertise, the potential for broader effectiveness of interventions, and competition. I think that could be viewed as a good thing. And then there are also things that are challenges, and from being from a local jurisdiction, it's really hard to figure out how do you work within the jurisdiction you're actually funded to work in, and then reach out in a sustained way to others that you really want to work with. How about the siloed funding streams? So that, in San Francisco, we're funded to work within a given jurisdiction. Alameda has similar siloed funding streams, and how do we try to figure out the challenges around that? There's a potential for loss of focus as we, if there are different patterns of epidemics in different jurisdictions, even though they might be very close to each other. And then there are obviously the political pieces, and then there's competition, which, depending on how you view it, could be seen as a pro or a con. So lots of implementations at the ground level. I think I've gone over these, and I want us to have some time for discussion. So I won't read through these in detail, but I do think that the last question is salient. How long do we take to declare a success or failure of a program? Something for us all to think about. And finally, I just want, in terms of looking at research, implementation research, and working at the local level, I just want to call out to the CFAR-Enhanced, the CFAR and Enhanced Comprehensive HIV Prevention Planning Collaboration. So the national strategy encourages collaboration between federal agencies and the medical and scientific community. And when CDC released its ECHIP plan, they released, so ECHIP is basically an enhanced comprehensive prevention planning program for the 12 jurisdictions with the highest HIV prevalence in the country. So 12 local jurisdictions got funded. They represent 44% of the epidemic. And CDC looked at the data and said, if you're going to do this, you have to use a certain core set of interventions. What's I think very salient to this discussion is that then NIH provided support for the local CFARs to collaborate with the local jurisdictions to provide a research focus to what's being done and a research focus to what's being measured. So a very important research health department collaboration that I think is very meaningful, and I think we can think about how does that actually scale up. 8 of the 14 required ECHIP interventions are being addressed through CFAR research. And as you can see, this is really a nationwide collaboration. And actually, Alan Greenberg at George Washington at the CFAR there is responsible for having the umbrella for coordinating all these efforts and making sure that we can not only look at local examples of what's working within the local health departments and the local CFARs, but really come from a national view about what's working and what isn't. So lots of ongoing implementation needs. I've gone through these. But I just want to also say that at ONAP, addressing the disparities remains front and central of what we're doing. I still, I lie awake thinking at night about that 48% increase, and we need to really make sure that we're doing everything we can to turn the tide of the epidemic among people of color. We're going to be having several consultations in June. One's going to be specific to blacks and the HIV epidemic and Latinos in the HIV epidemic. You can read the goals here, but I think 2 years into the strategy, with the data that we have, with the implementation, the universe of implementation and what's really being done now, this is an ideal time to have this conversation. What are the struggles? What's working? What's not? How do we move forward? So this is really going to be the focus of these two meetings, specific to addressing disparities among blacks and Latinos. So our goal is to realize the President's vision of the National HIV/AIDS strategy, that the United States will become a place where new infections are rare, and where they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstances, will have unfettered access to high-quality, life-extending care free of stigma and discrimination. I started with his announcement of the support for gay marriage. I think that's a critical step in the right direction. We're all very committed to working with all of you in this room to realize this vision. And I really look forward to having conversations today, conversations in the future as we move forward. You're the experts in the research, you're the experts in the room in implementation. Let's continue to do the work and affect meaningful change. So thank you very much. I want to acknowledge the tremendous contributions from the many people, including the people on this slide. Greg Millett lent me many of his slides and very appreciative of that. And I am all ears. I want to be as accessible and accountable and as transparent as possible. So please call me, email me anytime. I'm happy to have conversations with you. Thank you very much.
So Grant, thank you so much. That was an excellent overview and very specific to this topic and this conference here. And I think what I would like to do is actually call on Ann Donnelly to follow next, and then we'll have a joint discussion with the three of you. While Ann is coming up, Greg, I thought I would just give you the chance to add a comment or two to Grant's presentation in preparation for the question and answer, the discussion later, if you like.
Hi, good morning. I think that both Grant and I had an opportunity to take a look at the presentation beforehand. It's going to be an all data that's going to be presented from CDC, from people in this room, and from other places that really address a lot of the issues that's at the core of this conference, particularly during the International AIDS Conference. I serve on the committee for organizing the conference and have seen some of the really wonderful submissions that have come forward. And I think that there's going to be a lot of information that's going to be pertinent to what we're discussing today that hopefully will help move the field forward in terms of many of these issues. So looking forward to hearing your questions a little bit later. Thank you.
Okay, great. So Ann Donnelly is the Director of Public Policy for Project Inform, one of the United States' most influential community-based HIV treatment and information organizations. I will just add a plug for the forum. Ann Donnelly actually sat on the executive committee for a number of years, and it's great to have you back on one of our projects, and we very much look forward to what that might mean for the Bay Area.
Thank you very much, Veronica. Hi, everyone. I want to say that I really struggled with this presentation today because there's so much movement going on both in national healthcare reform and in what California is doing right now to prepare for healthcare reform that I didn't want to just do an information dump on you. So what I tried to do is think about how this might affect disparities and are looking at disparities. And what I think about healthcare reform is that in the long term, there's great promise to actually reduce disparities. But in the short term, frankly and honestly, I am very concerned that we will have a giant increase in disparities. And I wanted to take a look at why. So if we can go to, can I change the slides? Or? Aha. I'm not very technologically adept here. So I'm going to ask the panel to work with me also. I don't know that we can get through this whole presentation. I want to stick very closely to the 30 or 40 minutes that I have so we have time for discussion. So I tried to arrange it in such a way that we can get through the bulk of it and look at the most important things. I'm going to talk a little bit about considering disparities in the context of healthcare reform. Then I'm going to talk about what's on all of our minds. What do we think is going to happen with healthcare reform, with the Supreme Court and the elections? And then part 3 is, can we really afford to turn back at this point? Then we're actually going to look at what healthcare reform does for HIV and AIDS care. And then we're going to look at what California is currently doing right now. And last, we're going to look at the HIV community's priorities for implementation of healthcare reform. Because as you know, with healthcare reform, no matter what the promise is, everything depends on the implementation. So in terms of looking at healthcare reform and disparities, it actually touches on all of the things that we're concerned about. And in the short term, it touches pretty, with great magnitude, I think. We really have no idea at this point how people living with HIV and AIDS are going to get information and the assistance that they need to move from the Ryan White coverage into new forms of coverage. And what's happening in California right now throws a real spotlight on that. We don't have a communication system right now, much less an education system. We don't know what supports and services will be necessary with these new coverage, and we don't know who's going to pay for them, and how Ryan White is going to interact with the new forms of coverage in order to provide what our folks will really need in terms of being able to link to care. and actually find out their status. And then in terms of treatment and retention to care, we don't know what the benefits package is going to look like. We don't know what it will look like in individual states, and we don't know what it will look like across the states. So it's very confusing how we're going forward. So I think this is on everyone's mind. And obviously, before we had the oral arguments with healthcare reform, we all were convinced that the Supreme Court was going to uphold the entire act. After oral arguments, everyone went on this way downer. Some of us have revived. A lot of us really do think that the court will see fit to pass the whole act. That would be obviously what we would want to have happen. But there's a number of other things that could happen. The Supreme Court could strike down the individual mandate and leave the rest of the act. They could strike down the individual mandate and potentially take out portions of it. And lastly, the whole law could potentially be struck down. So we really believe that probably, at least at a minimum, the Medicaid expansion will go forward. And for our folks, initial estimates in California show that about 70% of our uninsured HIV-positive people will be eligible for Medicaid expansion. So that's a significant piece for our community. Additionally, in California, we believe that we've gone so far forward, it would be really hard to turn back now. We've had a lot of legislation promulgated that isn't actually tied to the Affordable Care Act, and so that would be potentially going forward. It establishes our exchange, it establishes our Medicaid expansion. So we're really at a place where we've moved so far forward, and we've actually extended care to almost 500,000 Californians that would have to be rescinded if we move back. So in California, we think we're kind of there. So regardless of what happens at the Supreme Court level, we think that our health care picture will be changed for people living with HIV and AIDS here in California. And then the only thing I can say about this is please vote. Get your friends and family to vote. This will have huge effects on how healthcare reform rolls out, certainly nationally, maybe a little less so here in California, but again, just vote. The question a lot of people are asking, particularly as we're seeing here in California as things start to roll out, and we're seeing a lot of challenges, and so people are going, wait a minute, can't we really just move back to where we had this sort of secure Ryan White? People with HIV were really helped and had wraparound services, and we were moving towards some real accomplishments in the epidemic. But the truth of the matter is we can't move back. The system's broken and really always has been for folks living with HIV. We've been systematically excluded from insurance, discriminated against from insurance coverage, and that's why only 30% of people living with HIV are uninsured, whereas only 17% of the general population is uninsured. We have thousands of people currently on an ADAP waiting list. The demand for Ryan White services is growing while the funding is remaining flat. And you can see that with looking at various studies, between 42 and 59% of folks who know their status aren't in regular care. So we're in a very serious access to care crisis right now, and we need health care reform in order to be able to begin to reduce the disparities everybody's been talking about. So what does health care reform actually do? And right now I'm talking about the broad, general, national health care reform. Can I just get a sense of how many of you feel like you're pretty grounded in what's going to happen in HIV care and health care reform in 2014? Okay. I'm going to take a little bit of time with this then. The first thing it does is it creates new responsibilities. And you've all heard about the individual mandate. That is one of the key pieces that's under consideration in the Supreme Court right now. But the interesting thing about this is if the coverage expansions go forward, if we expand Medicaid, if we open up the exchange and make them affordable for people, in essence, that is an individual mandate for people living with HIV and AIDS because of Ryan White payer of last resort rules. And we're seeing that in California right now. If there's a benefit in place that people can take advantage of, then Ryan White cannot pay for those services. So if people want to stay in care, they can't receive their care through Ryan White services once these coverage expansions are in place. So in effect, it is a mandate for people living with HIV and AIDS, regardless of what happens with the official individual mandate. So there are two strategies for coverage expansion. One is the expansion of Medicaid, which is, by the way, a huge victory for people living with HIV and AIDS, because as you know, right now, Medicaid for people living with HIV and AIDS is largely a disability support program. You have to be sick enough to qualify for Medicaid in order to get onto the program. So this is a huge victory. We've been fighting for this for about 20 years. The second route of expansion is through these health benefit exchanges, and I'll explain them a little bit more. But as I said, initial estimates in California, I think this holds true mostly throughout the country, is that about 70% of our uninsured folks living with HIV and AIDS will qualify for these Medicaid or in California Medi-Cal expansions. And the other 30% actually will qualify for federal help, we think, through the exchange. So not only is Medicaid expanded, but it's also improved pretty dramatically. Currently, Medicaid, as I said, is an HIV disability coverage for the most part, but in 2014, that disability requirement goes away. In addition, any of you who have struggled with Medicaid know that there's an asset test applied to Medicaid. You can only have $2,000 in the bank, so essentially they're saying if you take advantage of this, you have to remain poor. There's no way you can continue to save for a healthy life. That changes. The asset test is gone. So most people with income up to 138% of the federal poverty level will actually qualify for Medicaid expansion or Medi-Cal here in California. And I know you've probably heard this 133 federal percentage a lot, but there's also a 5% income disregard. So that means about $15,000 a year, $15,000 a year by 2014 for an individual, and they'll qualify for Medicaid or Medi-Cal. The other thing that it may do, and the reason we say could, is for this expansion population, they will qualify for what's known as the essential health benefits, which was a part of the law that was put into place under health care reform. But we'll look at the sort of what's going on right now with the essential health benefits to understand why I'm saying could here. This package may be more robust, if you will, than our traditional Medicaid or Medi-Cal, and it may not, depending on how it's implemented. The other strategy is these state-based health exchanges, and these are intended to be like insurance marketplace exchanges. And what they're supposed to do is make your choices much more clear and accessible in terms of choosing insurance. Importantly, for the first time in 2014, discrimination is going to be removed. Insurance companies will not be allowed to discriminate due to pre-existing condition, including HIV. But you know, a lot of us know people with varicose veins who have been excluded from insurance. So this is really helping everyone, including people living with HIV and AIDS. For the first time, we're going to allow it to be women and not have to pay more. That's a significant victory. There won't be any more, as of right now actually, there are no more lifetime or annual limits on the amount of benefits that insurance companies can pay out. And in addition, prevention services are going to be included at no cost in most plans, although there's a little glitch here that I'm not going to get into as well. In addition, for the first time, the amount of money that you have to pay out of your pocket will be capped. So you can only pay out a certain amount each year. So hopefully we will not be hearing stories of people going bankrupt trying to afford their health care post-2014. So the other important thing about these exchanges is they're intended to be like a marketplace. They're intended to be a place where it will be really easy for you to compare your plans and make good decisions about what plan is most beneficial for you. It is not going to be Medicare Part D, although this will be happening state by state. I can say here in California, we are advocating that it will not be like Medicare Part D. Any of you who have had experience of looking at those plans, and you all look kind of young, so you may not have, but it's a nightmare. There's about 38, 39 plans in one area. It's impossible to figure out what plan might be best for you. I've literally had people call me crying because they can't understand this array of benefits. So this, we hope, will look different, very different for people. Any questions before I move on? It's going to improve Medicare Part D, which is the prescription drug part of Medicare. For the actually last year, for the first time, when you reach that famous coverage gap, the Medicare Part D benefit works. You get a little bit of benefit. For people with HIV, it's about in the first 2 months of the plan year. And then most people with HIV go into the donut hole or the coverage gap, where you get no coverage whatsoever, and you have to pay full cost out of pocket for your drugs. As of 2011, the brand name drugs are giving a 50% discount in that coverage gap. Additionally, and this is huge for people with HIV and AIDS, Most people with HIV and AIDS, when they go into that gap, depend on the AIDS Drug Assistance Program to fill that gap for the drugs that are on the ADAP formulary. But up until 2011, it could fill the gap, but it couldn't count towards that trigger that moves you out of the donut hole. So it meant for most people that they would have 2 months of their Medicare benefit, which is a pretty big benefit, and then they drop into ADAP, and that would be it for the rest of the plan year. And here in California, we have a good ADAP, but it's only 184 drugs. So that's a big difference in benefit. Now people will actually be able to get out of the donut hole pretty quickly because the HIV drugs are expensive, and move into their full Medicare benefit. So that's a significant victory for people living with HIV and AIDS. By 2020, that donut hole or the coverage gap is going to be closed. Problem with this is that there will still be costs associated. It's not like it's going to be a no-cost benefit for people. So people will still need help in wrapping around that benefit to make it affordable. There's also improvements in mental health and substance use disorder. Now this is very much will depend on how it rolls out, because this is a first-time sort of effort. And what they're trying to do is actually integrate mental health and substance use disorder treatment into primary care. This is a bigger challenge than just saying it's going to be done. As many of you know, it's very different cultures that are coming together. There's a lot of questions that haven't been begun to be answered. And we got a little wake-up call in California. I went to a legislative briefing on this, and one of the legislators pointed out, we're 17 months from go here, and nobody's talking about implementation yet. We're still talking about how all this will happen. But again, it has promise, because it brings mental health and substance use disorder to parity, both in terms of benefits and also in terms of reimbursement for the very first time. So that's a significant increase. There's also a lot of opportunities in some of these integrated care models and programs to bring these two pieces closer together. But as I said, you know, there are challenges that we face in implementation. So, healthcare reform does establish a new mandatory set of benefits. It's only for this expansion population. So it's only for the new people to Medi-Cal or to Medicaid and the new people into the insurance exchange plans. However, we're going to talk about this in implementation. We had hoped that at the federal level, you can see that this is actually a good set of benefits, two big glaring gaps, vision and dental. But outside of that, it's a pretty good set of benefits. The problem is there's no details. And we had hoped that at the federal level, they would detail this very explicitly, and they would also be very, very strong about upholding the anti-discrimination language in the Affordable Care Act and what we think is the spirit of the Affordable Care Act, that all people who need a set of benefits should receive those benefits for comprehensive care. That hasn't happened yet at the federal level. We're still working on that, but a lot of this they have the federal level, or the Fed folks have directed to the states. So we're going to see what that means for disparity in states as states start making these decisions, and we'll see what's happening in California right now. The other thing the Affordable Care Act does is invest in prevention, wellness, and access to care and innovation. And these are actually really important parts of the Affordable Care Act. However, they're all pretty vulnerable, frankly. And even though we've seen a really strong investment, we also know that it could be taken away. So we've seen investment in Prevention and Public Health Fund. We've seen investment in community health center expansions to sort of expand and secure the safety net, if you will. We've seen some health workforce investments and care coordination investments. One of the things that they did in the health workforce investment is they did increase the reimbursement to primary care physicians, but it's only for 2 years. And there's not a strong definition about who a primary care physician might be. This is the absolute shame of healthcare reform. Immigrants, particularly undocumented immigrants, are completely left out of healthcare reform. Congress was nice enough not to apply the individual mandate to them, but literally they cannot purchase healthcare reform or purchase a health plan or access Medicaid at all. Undocumented people are completely left out of this. So this is obviously a real challenge for us and for folks living with HIV to continue to deliver the kind of care that we've been able to deliver to folks who do not have their documents. The other thing that we lost in the healthcare reform battle, we fought very hard, but right now there's a 5-year waiting period for legal immigrants to access Medicaid benefits. and we were unable to get that removed. So it's actually been codified in the Healthcare Reform or the Affordable Care Act. Here in California, we do actually provide emergency Medi-Cal and some other benefits to folks who are in this waiting period. We have a limited set of benefits. We hope that will continue, but in addition, California is working on something known, or at least some of us advocates are working on something known as a basic health plan, which is another opportunity for immigrants in that waiting period to be able to access a reasonable cost health plan. And the other small sort of piece that Congress did allow is immigrants in their waiting period can buy into the exchange and are eligible for subsidies, federal subsidies in the exchange. So it's a small thing for coverage, but a little bit. Questions before I move on? So this is what we think the care landscape will look like in 2014. And what I want to highlight here is that we have many more questions than we have answers about how the sort of basic benefit will look, what it will cover, and how Ryan White can integrate with its payer of last resort requirements to continue to provide the comprehensive set of benefits that people currently receive under Ryan White. So we're going to talk a little bit about what's happening in California. California is right now preparing for healthcare reform. This is not healthcare reform. A lot of people think that what's going on right now is healthcare reform. It is not. One of the things that happened here when California went forward is they went forward through what's known as an 1115 Medicaid waiver. And that allows us to change our Medicaid services, to have some interesting demonstration projects. Unfortunately, this really illustrates the challenge that we have as people living with HIV and advocates and providers for people living with HIV, because as a result of the silos, both at the federal and the state level, and as a result of HIV being such a small community and not being allowed into the development process of the waiver, and I want to just state that here in California we have a really strong history of working with our Department of Healthcare Services and our other low-income health advocates. And in spite of that, we weren't able to get to the table around the development of this waiver. And so they forgot to plan for people living with HIV. HRSA didn't talk to CMS. The State Office of AIDS didn't talk to the Department of Healthcare Services. And so no one understood the implication of this waiver for people living with HIV and AIDS. So as we started into these programs, the first of which is, I'm sorry, let me just quickly go to this. The first of which is a Medicaid-like expansion. What happened is that the counties and the plans did not know that people with HIV couldn't stay on Ryan White. So it was a huge disaster, frankly, and problem. We are now about a year into it, and some counties haven't even begun to transition people living with HIV and AIDS into these programs because they simply didn't plan for them. So we'll talk a little bit about that. But what I wanted to say about California is we have a huge opportunity because we are really embracing healthcare reform and we're moving forward very quickly, and that's great. And California has long been a leader in health and in health provision of health, particularly to low-income people. However, we're also in a horrible deficit situation, which a lot of states are. So what's happening is we're moving way too quickly. A lot of the programs or the development of the programs is being driven by the cost-saving idea as opposed to a real coordination of healthcare. That's underlying, and I'm not saying that people don't care about that, but they're really being driven by this deficit requirement to save money. So we're making decisions that haven't been fully vetted, and then some, and we're having extreme difficulty advocating for better systems. We're getting sort of shut down, which has never happened before. So it's an interesting and challenging time. For people with HIV, what we're facing is this giant transition, not only with all the change that's going on in California, all the movement to managed care, et cetera, but we have to find a way to transition both people living with HIV and AIDS and HIV and AIDS providers into brand new systems of coverage, which they are not used to dealing with. And it's really highlighted what's happened here in California with these low-income health programs, the movement into Medi-Cal managed care for all people living with HIV and AIDS, all seniors and people with disabilities, and also our pre-existing condition insurance program, is that it's really highlighted our challenges. We don't have an agency in charge of this transition. What it's really going to require is agencies that haven't worked together before working together in a very new way, and they're having a really hard time doing it. We're about a year into it. It's starting to happen, but it's very hard. They are having a hard time not being able to understand that just because they don't have jurisdiction over a program doesn't mean that they can't communicate about that program and engage people. We've found out that we have no effective communication system. Providers with HIV, some of them still don't know some of the changes that are happening a year later. Providers, sometimes people are walking into their pharmacy and their pharmacist says, you have new insurance. And they're like, really? So it's not even getting to the providers, much less the clients. Most clients know absolutely nothing about the changes that are going on in California right now. We don't have any clarity on what these new systems cover and what they don't cover. We have no assistance at all for individuals. We just, a colleague and I just did an in-service over at Ward 86, and we found out that they have about 4 licensed clinical social workers. They have 3,000 patients. The licensed clinical social workers are supposed to be working with their clients on adherence support, all the other important things for our linkage and retention and engagement and care. They're doing benefits counseling, and they don't even really know how to help people because of all the change that's going on. Our system is completely overburdened at this point. And then the other thing we're struggling with is the provider rates in Medi-Cal and in other forms of insurance coverage are completely inadequate at this point in time and much, much, much lower than the Ryan White reimbursement. So what is happening in California? The first is our Medicaid-like expansion that I told you about. They're called low-income health programs. They're a temporary program. They're going to end in 2014, and people will be transitioned into Medi-Cal managed care. The difference from large-scale or 2014 expansion is that these are developed, run, and financed by the county. So it's actually the county receiving the drawdown. The benefits vary. The eligibility varies hugely county to county. San Francisco only has 25% of the federal poverty level eligibility, and that's because they hadn't planned to cover people with HIV, so they had to move from 133 to 25% because of that surprise. Some go up to 200% of the federal poverty level. And then all the counties are at different stages of development. San Francisco has already started transferring people into the low-income health program. Alameda and LA County will not start before July 1st, and that's about 2/3 of our HIV-positive population here in California. The second thing that's happening, and people often confuse these two things, is we are moving all seniors and people with disabilities, including people living with HIV and AIDS, into Medi-Cal managed care. This excludes people who are dually eligible, so who have Medi-Cal and Medicare. What happened with that is that this was a part of the waiver as well. It was to be a rolling enrollment starting July 2012, ending July 2013. There was supposed to be a protection for people whose providers had not yet contracted with managed care, and many of our HIV providers had not because it was new, because it's a little bit complicated to contract with managed care because they differ in every county, so the requirements differ. So some providers were being asked to establish one primary care person in their practice and then have people funneled into the HIV providers. It was just all different, so the contracting was pretty complex. So there was statute that said that people whose, law, that said that people whose providers were not in this system and who had complex medical conditions like HIV, it was in the law, would be eligible for these medical exemption requests. So they could stay out of managed care for 1 year while their providers got contracted and everything got put into place. Well, what happened is that system, in spite of being in law, the Department of Healthcare Services decided that they had too many of the requests, and so they changed the system. And the system is completely broken now. It's completely arbitrary. It's completely subjective. We've had one provider who would put in a medical exemption request for someone who had multiple comorbidities, and the provider attested could not be safely transferred to another provider or transitioned to another provider, and that person got denied after 7 months. Then we have another person who had HIV disease, complex, but HIV disease, that's it, got approved. So there's absolutely no rhyme or reason to the system. It's completely broken. The continuity of care request, which is a little bit different, I won't go into it, but that providers never got any information about it. So they didn't know how to even apply for it or approach that. And certainly clients never got any information about it. And I could tell you a couple of horror stories, which I don't have time for and I won't go into. The other thing that's really big for people living with HIV and AIDS, and as I heard Grant talking about these regional approaches, I think it could significantly affect our ability to do regional approaches, is that we can't get people to contract out of county with providers. So that means that for many people with HIV who want to seek their care out of county, because they may feel discriminated against, they may not want to come out in their community, there may be specialty care in another county that they feel they need access to, we can't get them to actually be able to transfer. So you have to stay in your own county at this point. Even though the Department of Health Care Services says it's no problem, the plans aren't actually doing it. So it's a huge disconnect that we haven't been able to make any progress on. And I think it has implications for how we deal with regional approaches. The other thing is that's coming up that no one knows anything about, unfortunately, is the dual eligible coordinated care demonstration project. California is one of 15 states that's been approved for this. And they intend to go forward, including people living with HIV, with it's now 8 counties, including Los Angeles County, which holds about 40% of the Medi-Cal and the dual eligible population. So it's a huge, huge project. Most people think that it's going to fail because there's just been too much change, and this is now another piece of change with a very, very vulnerable population. It has passive enrollment, which means that it just enrolls people. It doesn't give them any sort of choice in the matter. It just enrolls them. It does allow a little opt-out period, but people may not even know they're in the plans, and then they're locked in for 6 months. And then it completely enrolls them in Medi-Cal managed care on the Medi-Cal side of their benefits, which means that the AIDS home health waiver, which has been delivering specialized care to folks living with HIV and AIDS for 20 years now and keeps them out of institutional settings, it's gone. So actually, we just met yesterday with the Department of Health Care Services and with the legislature, and I think we're going to get trailer bill language that excludes people living with HIV and AIDS from this particular demonstration project until 2014, because there's just been way too much change in our community. We're completely overloaded. We have no communication system and very little capacity at this point to help the people who would be moving in this project. And I'm not going to spend a lot of time on this. Every state has this. California has a pre-existing condition insurance pool. Again, it's a temporary program, ends in 2014. It's not been particularly useful for folks in California. A couple folks have signed up because the State Office of AIDS is able to pay for the drug deductible and also for the drug copays, but it can't wrap around the primary care currently, which is a huge problem for 2014 actually. And there's a $1,500 deductible in the primary care, so most people can't afford this program. So that's just a sort of a spotlight on all of the changes that are going on in California. And because of all those changes, we've been working with our national partners at the national level to sort of set up what are our priorities in terms of implementation for people living with HIV and AIDS. How do we help healthcare reform meet its promise? And I think you can see that we're going to have a lot of challenges to make this really happen. The first is what I talked about, the essential health benefits package. And because this decision-making has really moved from the federal level, although we're still working with them to see if we can get them to have strong protections around the anti-discrimination language, they have pretty much said the states are going to make this decision. What we know that means is that we are going to continue to see dramatic state disparities. If you look at Louisiana, if you look at Alabama, some of the states that are opposing health care reform, I can't imagine how they're going to get through all of this in time to put together a comprehensive, good, essential health benefits package. Even here in California, we're having we're having to work very hard on it. And the decisions are going on right now. California's making these decisions right now. We're involved in about 5,000 work groups trying to ensure that we get a good essential health benefits package and we get good protections in our state health benefit exchange and our Medicaid expansion. Our benchmark plan, and what this is each state now has to choose a plan that kind of defines the floor of the benefits. And California has pretty much chosen, it's not a done deal yet, but it's pretty much a done deal, the Kaiser small group employee plan or small group business plan for the exchange benchmark. It's a pretty good benchmark. We looked at the Kaiser large group, which was another possibility for choice, and the small group, and what we found is that the benefits don't differ that much. It's just the costs that differ. So we feel, and we also checked in with Kaiser, and they have a pretty strong clinician involvement in their scope of benefits decisions. So we think that it's a pretty strong choice. They actually just approved sexual reassignment as one of their benefits. So we think it's a pretty strong choice for our benchmark plan. Medicaid expansion, however, it can have a different benchmark plan. And we haven't even gotten final guidance from the feds yet on this, but we've already started advocating that what we go with is Medi-Cal plus any essential benefits that Medi-Cal doesn't currently include because of all the cuts we've had in Medi-Cal. Because what we know about this particular population, right at the 138 level, federal poverty level, is that income fluctuates a lot, and people are very likely to be moving between plans, what we call churning. And so we want as much alignment between the scope of benefits and also the provider networks as we can get between Medicaid, Medi-Cal expansion, and the insurance plans that are going to be offered. That's also why we're working on this option of a basic health plan for California, because that would sort of provide a bridge. It's almost like a Medicaid plan, but it allows people with up to 200% of federal poverty to engage in that plan. So we're working hard on that. Ensuring access to Ryan White, so filling the gaps. This is a huge issue. Whatever is offered, we're pretty clear by what's happened here in California, whatever is offered in these broader insurance plans is not going to be the kind of comprehensive care that people currently get and the medical case management that people currently get and the substance use disorder services and mental health services that people currently get. So we're going to have to work really hard with HRSA, with the State Office of AIDS, to get clear definitions about what's included in these various plans, and they're going to differ county from county because it's all in managed care at this point. So what's included and what can Ryan White continue to wrap around? And LA County with its low-income health program might be a great example to look at, because what they're doing right now is they're intentionally carving out substance use and holding that in Ryan White, and then they're also carving out a certain level of case management, because medical case management, because in the broader plan, you have to be very, very sick to get medical case management. We know that our folks need it for adherence support and for other types of reasons, so they've created levels. And they're going to say that the low-income health program only offers this one level, so Ryan White will offer level 2 or 3. But the difficulty here is that as of yet, HRSA hasn't engaged in this conversation. So we really need to, 5. Okay. And I just wanted to give you an example of why we're going to need Ryan White so much. This is Massachusetts. They have Romney Care, basically the same thing we're instituting right now. 2004 is when they put it in. Look at the total cost. Their total cost in ADAP has not gone down. It's actually gone up. It's just doing different things. So not only do we have a need at Ryan White to fill the gaps, cover the folks who won't have access to health care reform, but we're going to need it in our standard programs that we have right now. We're going to need it in our ADAP in order to make these programs affordable for folks. This is huge. I'm not going to spend a lot of time on it. I think what I told you about what was going on in California really illustrates this. And what we know from what's happening in California is that the people who are at risk are our most vulnerable people who really need individual assistance in both engaging with, linking to, and navigating this much more complex healthcare environment than what they've been used to. This is just a change, providers preparing for the change in HIV care and everything that's going to need to be done. It's moving so quickly in California. People aligned, providers aligned for the most part with Medi-Cal managed care. Now they got to align with Medicaid managed care. So it's just a huge issue of billing and contracting and authorization and things that our providers don't necessarily know how to do. Making Medicaid managed care work for folks, the train has left this station, but they say by 2015, almost 90% of folks in Medicaid across the country will be in managed care. So we need to understand how managed care works, we need to be able to engage with managed care, and we need to be able to make it work for people living with HIV. We did it. This is what we're leaving everybody with as we're going around and doing these healthcare dialogues, and I really, truly believe this. We need all of you. We need everyone involved in the HIV community to be involved in this discussion because there are no answers at this point, and there is no one agency who's overlooking this. So we really have both a challenge and an opportunity to build something that will do what we all want to do and not only provide comprehensive care but also reduce the disparities that we currently see in HIV disease. Thank you. These are just some resources.
That was an incredible presentation, Anne, and my head is totally reeling and swimming in the amount of information that you presented, and I'm not sure how the rest of you are doing. I mean, I don't live in California, so some of this may be especially strange to me, but it just sounds incredibly complex. But let's see what we can do here as a group and sort of, discuss the two presentations. Maybe, Grant, you would like to start off with maybe a comment on what Anne presented and how you see it from your current position.
So, is it on? You guys hear me? Should I shout?
It should be on.
I know it
Does this
should.
one
Yeah.
work? Hello. I think this one works. Grant,
This is on. This is on.
Okay.
So, well, thank you for the presentation. I think it really gave a very comprehensive and important overview at both the challenges and the opportunities that we face as the Affordable Care Act continues to move forward. And I think that there are a couple of things to emphasize. One is that, as I mentioned in my talk, there are already tangible benefits that the Affordable Care Act is having. I really appreciate, Anne, your point that things have moved forward and things will not be turned back. And that I think it's very important that we hold that, and that 2014 there are new things that happen, but this is a continuum, so it's not an either or, it's a both and situation. As a local implementer, formerly a local implementer myself, certainly the 1115 waiver dialogue, if we can put it that way, in California, and sort of the challenges that face have been really salient. I can say that at the national, in terms of the discussions with HRSA and ONAP in moving forward, those figuring out what are the lessons learned from that and figuring out how do we try to address some of those problems more proactively is very important. The other piece is this is tremendous system change moving forward, and whenever there's a change in a system, we can plan for what we anticipate will happen, and then there are always unanticipated consequences. So I think one of the questions is, as we all engage in this, is how do we maximize flexibility across the respective support systems so that when there are potential gaps, that those are able to be filled. And what I think is nice about your presentation is that it dovetails well with some of the factors that we are also aware of at the individual level, just by the fact that somebody is now eligible for Medicaid or goes into a healthcare plan doesn't mean that they're suddenly going to appear at the door of the clinician's office and say, oh, okay, now I'm ready for treatment. And I think that the data that we talked about this morning really makes that point. So I think in terms of implementing the cascade and improving the care cascade and really improving our 28% viral suppression level. The Affordable Care Act obviously is a huge structural change that presents many opportunities to do that. But as we embark on this, continue to do this, I think that the questions are, how do we provide support systems and fill some of the gaps? And we're actually looking at this at the federal level, looking at what the potential overlaps will be with Medicaid expansion, other programs expanding in relationship to Ryan White services are being used for now, and then what are some of the potential ways that Ryan White can potentially be used to fill some of the needs as we go forward. And one of the challenges, as Ann brought up, is the state-specific mandates now, and how to, or not mandates, excuse me, but the state-specific healthcare exchanges, and that we're going to have many different models to consider in many different populations in many different jurisdictions. And so again, I go back to the fact that we need to figure out as we move forward, how do we maintain and in many cases increase flexibility with different waivers and other options so that we get this right.
I think all of us agree an incredible amount of information and how lucky we are to have these leaders advocating for us. A couple things, both of you said kind of intrigued me, and I'd like a little more elaboration. One is that whole discussion, you talked about how long it takes to just start a research project until you actually report it. And I'm going, well, yeah, and then it takes at least twice as long to implement. So wait a minute, and now we're having this rush change of all this, so is there any money there to say what works? And I moved to California, it's a little over 4 years ago, and California is one of the, is screwy in the sense that the counties control everything here. And as opposed to coming from the capital of an individual state. So when I lived in Illinois, you decided in Springfield, everybody did the same thing here. And this business of it didn't make a difference where you lived in the state, and will make a difference. Maybe what we should do is have everybody move to San Francisco. I mean, what can we do? What's in the legislation that'll help us look at the cost, but also look at what effective works quickly? How can we change this dilemma? I mean, if we wait for things to go, it's going to crash. So I'm really concerned about some of the things you've stated, both have stated. So I wonder if you want to comment further. I don't know. Yeah.
Well, I could start. I mean, I don't think there's a system-wide easy answer, but I do think we have, again, some opportunities. I just wanted to be clear. I'm a huge proponent of healthcare reform, and I do believe that in the long run it holds tremendous promise for people with HIV and AIDS, even helping a little bit with discrimination, because HIV and AIDS is going to be much more integrated into the healthcare system, and there's lots of different diseases and challenges that people face. So I think that it will help, actually, in the long run quite a bit. But in the short run, I think we've got tremendous problems. One of their challenges, one of the things that we have been looking at is I didn't have time to talk about it, but there's the Center for Medicaid and Medicare Innovations, which is charged with coming up with innovative ways to integrate care, which is all of what the Affordable Care Act is pushing us towards, is integration of care. And so we are actually hoping that with our low-income health programs, we've applied for a plan amendment to Medicaid, to CMS, it's an HIV transition incentive plan. And we've been working with the state on this, and we're hoping it would give the counties more money to build infrastructure to appropriately serve people living with HIV under these low-income health plans. We're hoping that we might be able to convince CMMI, Grant, to look at these as a potential model. And the good thing about CMMI is that if, in fact, the Secretary determines that there is a improved health outcome and potentially some cost savings, the Secretary can actually apply an appropriate reimbursement level. So it could be a real win-win situation. I know that already some HIV advocates are working with CMMI in a different kind of model that integrates prevention and care. So it's kind of a long-term answer, but we're looking at that. And then in addition, we're working with the state on this duals project to, in lieu of including people with HIV right away, we've asked for demonstration projects and the California HIV Research Program, which is UCSF and UCLA, have funded 6 patient-centered medical home models. And so we're hoping that we can use that type of model and look at that for a demonstration project for integration of duals. So again, not an immediate answer, but some hopeful potential projects that would better incorporate people with HIV and AIDS.
So we have, oh, okay, go ahead, Brent.
Oh, no, I just wanted to, I'm glad you brought up CMMI, and I think that the model is really where we need to go, because in some ways the system is so large and complex that I think there's some real benefit thinking about how do we implement things locally, and what models can we actually use, and what needs to be adapted. So I think that that's a very important piece. I also wanted to comment on, we need more implementation researchers. This is something that is critically important. Going to your point about how long it takes to complete, even a randomized controlled trial and getting the results, how does that actually get translated onto the ground? I think that goes for some of our, very basic science discoveries in terms of HIV prevention, all the way through to application of healthcare policy. So I think that in the field there has been a recognition of this. I think in this room, there's a huge opportunity to have that conversation. How are people mentored in their career development or in this area? And so I think that there's a real opportunity to build on the fact that these huge systems are changing, that we need models, and then to really try to bring forth mentorship and support for it, and funding, quite frankly, for supporting research into these areas.
I just wanted to comment as a former provider, substance abuse treatment provider. I used to hate managed care. Remember those days? And hate managed care because they were going to lower my income and everybody. But it turned out that managed care was more effective in my agency, and that indeed it lowered costs, but we also will be able to offer more. So I'm not against this. I'm just concerned about the implementation levels that you already referred to, and I think it probably scares a lot of people in the audience.
Can I say 2 things about that? One is that we're not alone, because actually substance use disorder treatment and mental health treatment are in a similar situation to Ryan White, in the sense that they are being integrated fully for the first time. And they also, substance use disorder treatment has a federal block grant that they're going to have to figure out how to effectively utilize post this integration period. So I think that's a really important, another model that we want to look at, and another change that's happening. And then the one other thing, Grant, I was going to say, in addition to the implementation research, the California HIV Research Program has been trying to establish this piece of research that I think is actually incredibly helpful. And it would be interesting to me, I don't know how many other people do it, but it's rapid response policy research. And granted, it's not the depth or the academic rigor that we give to regular research, but it's incredibly helpful in the policy arena, because as you know, things change so quickly. So I would love to see that sort of broadened a little bit. It can be very, very helpful. And when it is done, what I know is particularly helpful about it is that it really needs to include both providers of services and advocates, because otherwise it can get pulled sort of back into that academia place that takes a little bit longer to resolve. So when we work together, that rapid response research is much more valuable.
So, and I wanted to comment on that too, and we do have a number of people here lined up for questions, and we'll give you the floor in a minute. But in terms of, even the IOM report and Paul Wolberning's work, in terms of the databases we have, the sources of information, so what are your thoughts regarding the data sources that will help inform us as we make this transition, because you're basically needing to evaluate as you go. Right? And so what is in place to actually capture what is happening and what is working, what isn't working, to then inform how to go on?
I think that's just it, is that there are different systems that we can actually look to for some data, but I think that we need to move forward as much as possible to a feasible and sustainable system that actually helps us measure across these different systems and across the different jurisdictions to see what we're doing and ensuring that we're having a positive effect. I think the Cascade data the fact that we now have a metric with regard to viral load suppression is very helpful. And then as we move forward in responding to the IM1 report and again aligning adhering to those principles of parsimony and harmony, we're trying to figure out, and I think we really need the expertise of many people, including many people in this room, how do we integrate those various disparate data systems in a way so that we can actually measure outcomes to ensure that what we're doing is actually improving the health and wellness of people living with HIV.
And if I hate to be this person, but if I can add one more challenge, what we're seeing in terms of just pure implementation is that unfortunately our data systems don't talk together. And so here in California, our AIDS drug assistance program data cannot be given to our low-income health programs. And therefore, we can't actually use those data to guide or monitor transition. So we have another challenge of ensuring that we have data systems that can talk to one another if we're actually going to look at these quality measures.
I'm going to interrupt.
We have no HEDIS measures for HIV.
And say to Greg, at SAMHSA, there was a push to have a level of research scientists who were allowed to cross data systems with the human subject issues resolved and special recognition that has been stopped at the top of NIH level. Could you please get involved so we could actually cross data systems, please?
Well, I think you bring salient the point that the integration and sharing of data is really a critical piece as we do this. And one of the things that we're actually currently reviewing now is sort of what are the policies and what are policies versus laws versus regulations. Where can things be shared? And obviously, protection of data is paramount. And I think that we can both make sure that data is protected and that it's used in a more meaningful way to monitor our outcomes.
Actually, Veronica, you asked my question, which was about the fact that people are going to be out of the Ryan White system, and so the data collection from that resource is going to go. And of course, I just want to thank you guys because actually that was a great presentation. It simplified a lot for us, and of course Grant, who is always a great speaker. So I want to thank you guys. I'm very busy to thank you all both for excellent talks. I do think this program, the changes can improve care, particularly the comorbidities that we're seeing with our patients, but there is the risk of some HIV expertise being diffused, diluted as people, as patients have to now go to primary care. So I do think this question of how we track the outcomes is a critical one, and funding for finding ways to have systems communicate is essential. But anyway, you guys already commented on this. Thank you very much.
So we'll have
Thank
Eddie
you,
next.
Malcolm.
Hi Grant. Hi, I'm Eddie Mottinger from UCSF. One question for each of you. Do you anticipate the medical services for ADAP being eliminated and only preserving in ADAP the wraparound services? And I ask that out of concern because the Medicaid reimbursement for HIV medical services is so floridly inadequate that, for instance, in my institution that accepts Medicaid, we use them for the uncovered Medicaid services. So when a woman comes in for care, we cannot bill Medicaid for a primary care visit and an obstetrics or gynecology visit. So we bill to Ryan White the visit that is uncovered. We have separate healthcare maintenance visits with a nurse to take care of all of the required healthcare maintenance and trauma screening and prevention with positives and vaccinations that go along with visits that are completely uncovered in a $60 reimbursed Medicaid visit. And I fear that there's a magical thinking that a person with HIV, especially a triply diagnosed or doubly dual diagnosed patient, could get adequate services covered in a single Medicaid visit. That's my first question. Second question, that's for both of you. And then, I feel like I only have one chance. And the other one is, it seemed yesterday there was a question raised about the allocation of Ryan White now being done through HIV incidence instead of through HIV prevalence. The recent Part D competition clearly favored regions of the country where there is increasing incidence and not stable or even competitively high prevalence. And I fear that what will happen in San Francisco is there another bit of magical thinking that if they eliminate the Part D or the Part A monies, that somehow because San Francisco has other resources, it'll make it up. And instead my clinic or other clinics like ours will just close and those patients will collapse into inadequate primary care systems. So if either of you have comments on that. Thank you.
So thank you for those questions that I think are really critically important. And I mean, I don't think that anybody's ready to speculate yet on the specifics of the future of how specific funding that is currently used to do certain things will be used in the future. But I do think that you bring home the point that, again, the flexibility, and as we look at this changing environment, where are the gaps going to be and how can we try to fill those gaps? Ryan White, yeah, obviously, it's just sort of for people, I don't know, did you say in your talk that it's due to expire in 2013, just so we have...
No, it's to be reauthorized,
reauthorized
but there's
yeah.
no hard sunset this time.
Right.
So we can choose, and from an advocate's point of view, I know Grant, but from an advocate's point of view, what the discussion in the community is right now is that we probably would not push for reauthorization because, for example, family planning hasn't been reauthorized in 30 years, and that's not a problem. It just keeps the act at its current level with its current components. So that's the community discussion.
So I think that that's the community discussion that obviously we want to hear from, and I think that the point is that this is potentially an opportunity to think about. It is an opportunity and will be an opportunity to think about what is the future of Ryan White look like? How does it make sure that it's meeting the needs in the context of the other pieces that are going to be implemented? So I don't have a specific answer to your really important question, except to say that we need to be very aware of this. We need to figure out how do we maintain the flexibility in these different funding, and also recognize that things are going to change, and that while most of this this is good change moving forward, there are going to be ways that we need to figure out how do we ensure that gaps continue to be filled. I think also, since you brought up ADAP, quite one of the challenges at the federal level, and I think that this, Anne mentioned the state-specific coverage and how that's going to, the states are going to be able to determine to a large extent what's being covered. ADAP is an example of the challenges that the federal we face at the federal level in terms of gaps, right? Because, for instance, the President's 2013 budget puts ADAP funding at $1 billion right now. And if you look at the federal contribution to ADAP, it's actually increased over time. There are ADAP waiting lists, and really the reasons those continue to exist is because states are not stepping up and putting in an equivalent amount. If you look at the increases over time, the state contribution has actually decreased dramatically. So I think these are some of the things that are continuing to occur that we need to be very aware of as we figure out where do we go with healthcare as we move forward in the future. So we need to continue to have these conversations. There's a lot to continue to address, and I think as long as we continue to share things that have worked and models that have worked, that's really going to help us inform how to address the challenges moving forward.
So I do have a specific answer for your Medicaid question. Unfortunately, it's not a good answer. If the person is covered by Medicaid, then Ryan White cannot step in and cover any portion of the benefits that are covered under the Medicaid plan. So if in your capped rate from your Medi-Cal managed care plan, I assume you're with San Francisco plan, if those services are covered under San Francisco plan's capped rate, then you can't use Ryan White money to supplant them or to support them. You have to figure out, and that's what I said we're really struggling with, you have to figure out what your capped rate includes, and then what services might be needed over and above that Ryan White could continue legitimately to cover. Because if they're covered, Ryan White can cover services that aren't covered, but what it can't do is if Medicaid pays you $6 per visit, it can't pay you then another $25 in order to adequately cover that person. So that's the struggle, and unfortunately that struggle is going to be so individual because each managed care plan within the state of California has a different way of paying out its rates.
Okay,
So
we have
that's a tough
Susan
one.
next with a question.
Hi, Grant. It's nice to see you. The cascade of care is very compelling. What I haven't seen so far is a breakdown of disparities. And so obviously it's an average across all groups. From my experience now, I've been doing a project in Dallas, Texas with young black gay men. And the difference between here where I'm used to young white men, and there is incredible. And I don't even mean access to care. I also mean, I've heard of probably 10 deaths of guys between the ages of 18 and 30 in Dallas and Houston just in the last year and a half. Guys just don't get in. You know, there's so much stigma. Yeah. So I'm wondering about, you know, what the thoughts are about that there are probably glaringly different cascades of care, of rates, and how those are being considered.
So thank you for the question. Those are incredibly salient points, and the cascade of care broken down by race, ethnicity is we expect to have those data soon. So I think that will really be informative in helping us figure out the puzzle.
Hey, thanks both for terrific presentations. And thanks, Grant, for calling out the Kaiser results from yesterday, which I think the headline is, if we can get people care and keep them in care, disparities diminish. And what I'm struck by is both of you touched on the prevention fund, and healthcare reform is two parts. One, it's getting people into care, and there is an incredible level of advocacy, thank God, and an incredible degree of specificity, thank God, and to you, about how to move that ahead in terms of getting people into care. When it comes to the prevention fund, I'm always struck by the contrast in that there's very little strategic specificity, there's very little advocacy, and while all of us in HIV and STD prevention can recite chapter and verse vaguely that we need to reduce disparities, that we need better neighborhoods, that we need jobs, that we need education, we need all the things that the prevention fund is aiming at specifically around chronic disease, we have just begun the conversation. It usually stops pretty quickly. And I'm wondering, since you've been in Washington, do you have a better sense of, are those conversations getting more specific? What are they about building bridges with the chronic disease folks and addressing some of the same factors we are? And do you see any hope in that arena?
So those conversations are happening. I think that there's a lot of hope moving forward in the arena. I think that there's a lot of active conversations about how do we sustain how do we move forward and sustain a public health system within the context of these changes that Ann is talking about. And I will say that, you know, there's one thing that I'm struck by is when people ask questions, you know, implementers are asking questions, people are really committed to being responsive, and there are a lot of things that, you know, your perspective and other people's perspective on this room are very important to bring forward so that we can help answer the questions that you're bringing up. There are a lot of people working on all these aspects right now. It's obviously a huge system. Many of them haven't been implementers on the ground for a long time, if ever. So I think that as much as people can bring forth, you know, here's the concerns in my community, I think that the 1115 waiver experience was something that we really learned from. Going back to your question about the prevention fund and how that's actually being integrated, I can't remark specifically on, you know, specific programs that are doing that. I'm sure that there are things that are actually happening. But I think that what we're really aware of, especially at ONAP with regard to HIV prevention, is we need to ensure that there are ways that people can continue to get HIV testing, STD testing, comprehensive support services in medical settings, as well as other programs, so that, you know, the community-based organizations, which have really formed, you know, a strong backbone of what we do in HIV care and prevention, while what they do and the skill sets that people have there will need to change in some cases, that prevention remains front and center in terms of what we're doing looking across the system and in terms of achieving the national strategy's goals.
And can I just comment? I totally agree with everything Grant has said. I think the challenge that we face is we're dealing with a very difficult deficit environment, both at the federal level and at the state level. And frankly, the first thing to go is often the prevention. That's why the Prevention and Wellness Fund is at so much risk and is so vulnerable right now. And that's why we here in California lost $85 million in services. All of our prevention efforts at the state level are completely gone. And even within ADAP, which is our only program left, the governor is imposing ridiculous unbelievably large amounts of cost sharing, which I think we just won actually out of the legislature and got it defeated just a couple of minutes ago, I think. So keep your fingers crossed. But I think this vulnerability, because of the deficit, it's not because of people's great intents of really trying to bring forward this really important, I think, realization that the country, this dialogue that we're having about how important it is, it's more this deficit environment that we're facing that's making it so challenging.
Hi, Grant, and thanks so much. You know, it's so critical, the work that you're doing, because policy is one of the boxes that's upstream, and that really does impact health inequities one way or another. So I think it's just so critical. I want to sort of bring points from both of your talks to ask about and it follows a little bit in terms of the prevention question, but trying to understand if that combination that, Grant, you showed, and the tremendous impact that we will have if we can really effectively implement a whole combination of interventions at all levels, including PrEP, test and treat, you know, and linking and keeping folks in care. I don't hear on the policy agenda, well, for example, how will PrEP be covered? And I want to link to Ann's point about that there could be actually more disparities that come about with healthcare reform. And in the short term, perhaps, although I'm much more aware, and we'll be talking on the next panel about all of the agencies that are currently serving and probably the only gateways into what I think is the majority of people who are out of care, and those agencies are going to collapse in the reform, and who will be left to go out and actually locate the enormous amount of folks that we're trying to locate, and that we're starting to understand what it takes to actually get them into care. So I see it both on the prevention side, where is PrEP going to work, and then I see it on the care side. So if you could speak to that, I'd appreciate it.
So I think that your PrEP question could sort of be viewed as, you know, medical technologies and how do people access medical technologies in care. And I think if you look at the history, obviously people who are better, well, not obviously, but the data pretty much show that people who are better off tend to access care and medical technology faster than others. So it goes right back to the slide that I showed, that as we develop more effective HIV treatments, the disparities actually got greater. And I think that there's certainly that risk for PrEP. On the other hand, I think that if we think about PrEP as an opportunity and PrEP as not only a medical intervention, but if we think about it as combination prevention, because, you know, as IPREX made salient, PrEP is not just about providing a pill to somebody to prevent HIV. It's really about a comprehensive approach to somebody's sexual health. I think if we think about those models and providing an opportunity to have conversations about people, about health, to address HIV testing, to address the stigma and discrimination, that, you know, I think that if someone's even considering PrEP, you have to have that conversation with somebody about, you know, what sort of behaviors are you engaging in, you know, so I think that PrEP could actually provide a forum for the discussions to actually engage and link people into sustainable care. The question is, how does that actually happen in this changing environment? And that's where I think what you brought up, we need to ensure that organizations that have historically played this role are able to have the support and the resources to shift to these new paradigms, so that if you're not necessarily a medical setting, that you actually do have a relationship with a medical agency, so that when you're actually providing the support and people are walking in your door for substance use treatment or for HIV testing or for housing assistance or for job training, that you're actually able to have the skills necessary to help them negotiate linkage and engagement in care. So there are a number of people and organizations working on this now, and I think that as we can continue to prepare for this, we need to continue to have these conversations, and the system will be able to support organizations that do that. And I think we're very clear at ONAP that unless we're able to support that, we really are going to not achieve the goals of the strategy. But I do think it's a matter of skills training, education, technical assistance, and going back to Ann's point, within the limited, within the challenging resource environment that we're in.
So I'm glad you brought up the longer term, because I was trying to be optimistic, but I think actually, Cynthia, your view is more realistic. So I want to speak to that for a second. PrEP coverage. In the short term, I honestly don't know. I think it's demonstration projects and drug assistance programs. I don't see at this point the AIDS drug assistance program wasn't even able to cover the new Hep C drugs. So I don't see, and it actually can't pay for drugs for people who aren't positive. So I don't see a logical form of coverage for the actual drug itself outside of those two things, the demonstration projects and the patient assistance programs. In the longer term, I was at the CDC consultation for coverage. It was about a year ago, I think, and actually surprised at the larger insurance companies, which said that they probably would have no problem covering PrEP because it was cost effective, and even some of the Medicaids. However, I do want to couple that with the deficit environment that we're in, particularly for the state Medicaids. So PrEP coverage, that. The second part, this is completely Ann Donnelly opinion. This is just something that I have been watching as I've been watching this stuff unfold in California. And one of the thoughts that's coming to me is our sort of peer outreach needs to make, is essential and needs to make some very important changes, I believe. This is personal, completely my opinion. I think that we should be looking towards community health worker and promotora training and certification with an HIV component in it. I think if we get our peer navigators, educators certified under community health workers, which I think are going to be an important part of the healthcare system, that we have an opportunity possibly for even some funding under ACA, possibly, although I don't know. But definitely I think we can then really support we can fight as a community at telling Congress we need Ryan White money to ensure that our community health workers and promotoras are actually out in the community and doing what we need to do to change this cascade. So that's my personal opinion, but I think I'm about to go on a soapbox with it. And I know that City College actually has either a promotora or with an HIV component in it, and I think that needs to start happening across the country, frankly. And I'm hoping that HRSA will kind of take up that dialogue and really discuss it.
And I would just say that those are definitely models that are being taken under consideration right now.
Wow. Are you guys going to be around for a while during the break and be able to talk to people? Okay, great. So we're about to enter a break after this incredible discussion. Aren't we lucky to have leaders who've been in the trenches who know what they're doing? It appears so. So thank you, guys. All right, we have a 20-minute break. Please look at the presentations in the back of the room as well